Hello, my name is Ian McCall, and this is tutorial number 5 in the Ken Peever series. Now, today we're going to look at painful nodules on the leg, conditions with central umbilication. That's a very characteristic feature. You know, if you see central umbilication, probably the commonest thing, obviously, is going to be molluscum contagiosum, but it may be things such as cryptococcosis, and there are a few others that we'll discuss. Causes of macroglossia. Again, an important sign. It usually indicates some significant pathology if someone has macroglossia, especially if you're getting indentations from the teeth on that tongue. And the recurrent pyodermas, particularly of significance in young children, because there's a variety of inherited syndromes that can have eczema associated with them, which means they're likely to be sent to you, but they're getting recurrent pyodermas as well. And then we're going to look at some of these things: painful nodules, causes of Palmer pits, causes of pruritic papules. God, that one's going to be a bit large. Lymphangioma circumscriptum, very distinctive lesion when you see it. Boenoid papulosis, perhaps the opposite, not really a terribly distinctive lesion. In fact, it can mimic, if solitary, it can just mimic a seborrheic keratosis. It's only when there's multiple that you tend to think of this particular disorder. Papular urticaria, now that's a really common disorder. We see lots of papular urticaria, and sometimes it's difficult to nail it to a particular biting insect. In the vast majority of cases, it is some form of biting insect. And erythema nodosum, always worrying when it occurs. Let's first of all look at painful nodules in the leg. These were the differentials that Ken felt were important. Erythema nodosum. Again, it's the distribution of this. It's the anterior shins that you're going to see these. It occurs in crops. Initially, there is a red, tender lesion. There's no surface scale. And as it evolves, a bit of bruising may appear. You can get one lesion, you can get several lesions. The bruising is because it's a vasculitic process. There's damage to the vessels in the fat septae. So it's a septal paniculitis, erythema nodosum. What about subacute nodular migratory paniculitis? Lovely big name, that. Basically similar features to erythema nodosum. The lesions are more spreading and can continue to go over a 6-week period or longer. Remember, if you're going to do a biopsy in erythema nodosum, because it's a paniculitis, make sure you do an incisional biopsy and get a wedge of tissue down to the fat, because you've got to do this to see where the damage is. The pathology is deep, and punch biopsies may not be able to find that for you. This subacute migratory paniculitis, as I say, we've said it's similar to erythema nodosum, but it tends to occur in older women. And usually the lesions are unilateral, or they're asymmetrical if bilateral, whereas in erythema nodosum itself, generally you've got symmetrical bilateral lesions. Generally, in the subacute variant, the lesions are painless, or at least they're not as tender as in ordinary erythema nodosum. And typically, you don't find underlying diseases, not in the same way as you do with erythema nodosum itself. Remember, erythema nodosum is a reactive process. It's most commonly associated with streptococcal infection, and certainly in kids that's the most most likely cause, but a variety of infections can in fact do it, including tuberculosis, Yersinia, Salmonella. There's a whole variety of them, and certainly in North America, some systemic fungal infections, histoplasmosis can be a cause. So when you see someone with erythema nodosum, you go looking for an underlying cause. Now, the other condition that you've got to think of is sarcoidosis, and especially the combination of respiratory symptoms with erythema nodosum and an X-ray showing hilar lymphadenopathy, and that's called Lofgren's syndrome. Now, the next lesion here is polyarteritis nodosa. Now, it will give painful nodules in the legs as well, usually along the lines of blood vessels. But the other feature that you may see here is livido. But the livido with nodules is more likely in the cutaneous variant. The nodules are going to be seen along the vessels. But systemic polyarteritis nodosa, where other areas of the body are involved as well, other internal organs, certainly livido can occur there as well. Erythema induratum, different condition. In contradistinction to erythema nodosum, it involves the calves. And again, it's usually in an older female group. There may be no, they're often painful. There may be ulceration, sometimes there isn't. But we're commenting here that in the younger age group with erythema induratum, there may be no pain but ulceration and erythrocyanosis. This is a lobular paniculitis. It's usually the lobule of the fat that's involved in erythema induratum. It used to be thought to be a tuberculate, that it was associated with underlying tuberculosis, but that isn't always the case. The other name for this is nodular vasculitis. See, we put this underneath. We've said that that's usually seen in women in the 30 to 60 age group in the legs. Symmetry is unusual, usually tender, small nodules that may ulcerate. I think they're all part of the same process. I think it's the same condition, erythema induratum and nodular vasculitis. Difficult conditions to treat these. We'll go into that later. Erythrocyanosis with perniotic nodules. Now, again, in some parts of the world where it's very cold, then, and especially horse riders, people that go out early in the morning when it's cold, then they can get these painful nodules in the legs, but often it's on the buttocks as well as the leg. And it's a form of cold injury where the underlying fat in some way insulates the overlying skin, and they get an equivalent of a buttock chilblain, but it extends deep enough sometimes to involve fat tissue. And then there's other causes of paniculitis that may cause painful nodules in the leg, and the one to watch for is pancreatic disease, where they've got pancreatitis or pancreatic cyst, a bit of abdominal pain. And these lesions can ulcerate. The patient's usually quite ill, and the lesions can be quite extensive, but there's less bruising. That is a lobular paniculitis. Pancreatic paniculitis is a lobular paniculitis. So there's less bruising than erythema nodosum. It's due to the release of fat-dissolving enzymes from the damaged pancreas. And then lastly, leprosy. When leprosy is being treated, especially lepromatous leprosy with a whole lot of organisms, then they can get a treatment, a reaction, and part of that is immune complex formation, and the immune complexes are deposited in the vessels in the septum, and so again it's a septopaniculitis, but they get erythema nodosum-like lesions. In fact, in some parts of the world, that's one of the commonest causes of erythema nodosum, is leprosy treatment reactions. Erythema nodosum leprosum, I think, is the name that they call it. So, painful nodules in the legs. Erythema nodosum, subacute nodular migrating paniculitis variant, perhaps cutaneous polyarteritis nodosa, erythema induratum and nodular vasculitis, erythrocyanosis with perniotic nodules, pancreatic paniculitis, and erythema nodosum leprosum are the things to consider. Erythema nodosum itself is usually in younger people, Erythema ingeratum is an older age group. This was an image of Sweet syndrome. They can give nodules in the legs as well. Typically, it's a lovely colour for sweets. Looks sort of like lymphoma. It's an infiltrate sweets. It's an infiltrate of neutrophils, mainly into the dermis. And sometimes it can cause pseudopustule formation here. Some of the neutrophils actually go through the dermis into the epidermis. And it can cause edema, pseudoblistering as well, with some lesions because of the edema that's actually in the dermis. Again, another disorder altogether, but you go looking for underlying problems if you've got sweets, especially your bowel disease, your ulcerative colitis, your Crohn's, rheumatoid, and look for blood abnormalities, especially if you get the variant with pseudoblistering in the back of the hands. Okay, another topic, recurrent pyodermas. We've said here pyoderma is a rather non-specific term. Lesions produced by pus-producing bacteria. They can take the form of pustules, crusts, or ulcers. This is important. Sometimes there's a background problem in these patients. There's something wrong with their immune reactivity. And they may have atopic dermatitis. They may have, and especially in some Aboriginal communities, recurrent scabies as the cause of their pyoderma. Infected insect bites. Not an uncommon cause. People get an insect bite and the insect bite gets infected. So you've not only got to deal with the infection, you've got to deal with whatever the biting insect is. Herpes simplex. It can be superimposed on a variety of conditions. The one you've got to really watch for is atopic dermatitis. Contact dermatitis resolving in impetigo. We've said the pyoderma may hide underlying disorders. Yeah, okay. Most leukemias in infants and neonates are going to come on quickly. You're not going to get recurrent time for recurrent pyodermas, I wouldn't have thought. And we've said that there's some immunological disorders presenting with pyoderma, and we'll go into some of these down below in a minute, especially the ones with associated atopic dermatitis. And the two to really consider or remember or know something about are the Wiskott-Aldrich syndrome and Job syndrome, the hyper-IgE syndrome. This was a Medscape review. I don't know if this will open up. Give me a second to see whether it will. Nope. Short answer. Nope, it will. There must have been some. Yeah, this was just child with atopic dermatitis. And a little chat about Wiskott-Aldrich and Job syndrome, some of these other things that are associated with recurrent infections. If you're interested, have a little read at that. Amy Paler. Is that Amy Paler? Yeah, Amy is a very good pediatric dermatologist. Worth having a little read at that. Let me get back to the right page. What's this one? Why have I got leprosy, histiocytosis here? I think because this rash, if it occurs, you're going to get greasy-looking keratotic papules, and they're going to be in seborrheic areas, and it may look like infected seborrheic dermatitis, but it's actually a form of Langerhans cell histiocytosis. I think we've got a picture of that that we'll come to a little bit later. But just remember that keratotic, greasy-looking papules, seborrheic areas, child ill, perhaps with hepatomegaly or splenomegaly, then histiocytosis. Note, the take-home message is that pyoderma and eczema in the newborn and neonates should also make you consider some of these congenital immunodeficiencies of blood diseases and histiocytosis. Now, these were some of these congenital disorders that can be associated with recurrent pyodermas, and they're all rare. Chronic granulomatous disease, Chiari-Higashi. You can look these up in eMeds if you want to know a bit more detail. The Wiskott-Aldrich, I think, an important one. I've put a link there to this condition in dermis. In DermNet. I mean, you can look it up in eMedicine as well. You get a lot more detail there, but often DermNet will give you the gist of what you need to know about the Wiskott-Aldrich syndrome. There are always variants of all of these. I don't think you can remember everything, about all these disorders unless you've got an exceptionally good memory. The main thing is to have triggers, clinical triggers, when you're seeing patients that make you think about these disorders. You just remember the name. You can always then flick into the books and see what the other various features are. But the main thing is that your brain triggers you into thinking of these particular problems. So you can go in there and have a little read about Wiskott-Aldrich. Bruton's gamma globulinemia, ataxia telangiectasia. Worth having a little look at this one, simply because it's got some good cutaneous signs as well, especially with telangiectasia, that's marked in periocular areas and things like that. And, not only do they have the skin signs, they've also got these progressive neurological impairments that come in as well. So we've got a picture of that, or a case of that somewhere, that I'll show you the picture later. Some of these other disorders with recurrent pyodermis, Behçet's, leprosy we've talked about. Some vasculitis can present with pyoderma-like lesions, and then Job syndrome, the hyper IgE syndrome, again with features of atopic dermatitis and susceptibility to recurrent infections, pustules, boils, etc. But very high IgE. By the way, if you want to learn more about the histiocytoses, there's a lecture here, I think it's from the MD Live series. Errol Gusak is the presenter. Errol was one of the presenters at the Australasian Dermpath meeting a few years ago, and he's very good. Oh, this picture here. This was disseminated histiocytosis, or letter-seaweed disease. Relatively young child. Look how it's brownish, greasy type papules. Admittedly, that's on the back, but it's a youngish sort of child. It sometimes looks almost like Darius. If you're more likely to see Darius than you are to see histiocytosis. But the same sort of thing should come to mind. Pruritic papules. Okay, well, we've said the commonest of the pruritic papules are going to be seen in atopic eczema, but certainly you've also got to think of scabies. Pruritic papules, instantly atopic eczema or scabies. In atopic eczema, the papules may coalesce and form areas of lichen simplex, just with thickening of the skin with chronic rubbing. Also, though, itchy pruritic papules, Grover syndrome. So atopic eczema, Grover's, scabies are the three sort of things. With scabies, what you do is you go looking for the typical areas where you expect to see scabies, in between the fingers, anterior axillary folds, umbilicus, genital areas. So you go looking elsewhere. Grover's, you expect to see these red, scaly, itchy papules, particularly under the breasts, on that lateral chest wall area. More common in the elderly with sun-damaged skin, and there may be a bit of surrounding eczema as well. Atopic eczema, well, the normal distribution depending on the age. And that's the thing about atopic eczema, the distribution varies and changes with different ages. What other unusual itchy papular eruptions? Giannotti crostei, it can be itchy. Remember, Giannotti crostei is going to be papules mainly on extensor aspects of the arms, the legs, on the cheeks, but not much in the trunk of that at all. And often they're not itchy, at least the ones I've seen. Remember, it's usually a reaction pattern to an underlying virus. In the majority of cases, there's a whole variety of viruses that can do it, although initially I think it was Hep B virus was the one that was reported in the initial papers by Giannotti and Crostei. Itchy papules can also be seen as a dermatophytid, where you've got a dermatophyte infection elsewhere, and itchy papules come up almost as an id reaction. there's one here that's called a pediculid, an id reaction seen in 25% of cases of pediculosis capitis. By the way, with pediculosis capitis, the classic presentation is the girl with long hair who comes in with an itchy dermatitis in her upper back and her neck, and you look there and you see some features of an excoriated series of itchy papules. Well, what you should do is look in the scalp, look at the hairs, look to see if there are any hair casts, there are going to be any knit casts there. Remember, they're fixed to the hair shaft, whereas a hair cast can be moved on a hair shaft. What else have we got here? Other pruritic papules. Lichen planus, yeah, it's an itchy condition. The papules are going to be at the wrists. They're going to be purplish, usually in the palmar aspects of the wrists. DH, sure, itchy as well, but again, distribution is going to be at the elbows, over the scapulae, over the buttocks. Though it's one of the immunological blistering diseases, you often don't see blisters. The only time you actually see blisters in DH, or at least in my experience, is when they've been on dapsone for treatment, and then they come off the dapsone for one reason or another, and suddenly, boom, the blisters come up again. Very itchy, underlying gluten hypersensitivity, IgA in the dermal papillae. Scabies, we've talked about. Look at the typical areas, papular urticaria in the lower legs, particularly in houses that have pets. Grovers, we've talked about. Fox Fordyce. It's curious, the papules are in the axillae. Sometimes they look like sort of vesicles. And it's, there's a variant that's just gone out of my head that will come back in a minute or two that can be confused with Fox Fordyce disease. Particularly common in women, that condition. And then there's prurigo nodularis. Again, that's on the lower legs and on the arms, on the cape area of the neck. It's due to chronic rubbing and scratching. It's, another name is Picker's disease. It's really an obsessive compulsive problem. Although some individuals just seem to be susceptible to get prurigo nodules. Obviously, atopics are a bit more susceptible. So these are other itchy papular disorders that you soon learn to recognize both from their morphology and from their distribution. What have we got here? Papular urticaria. Actually, before we do that, let me just flick into Fox Fordyce. Well, let me see this image of Fox Fordyce. It's interesting. Their other name for it is apocrine miliaria. These are the lesions here in the axillae. Itchy axillary papules. Young woman complained of a persistent itchy rash in her axillae and developed during adolescence. Rash disappeared during the third trimester of first pregnancy. It recurred several months after delivery. Eruptions typical of apocrine miliaria, Fox Fordyce disease. I don't know how to treat it. Okay. Actually, have a look at e-medicine and Fox Fordyce and see what they say about treatment. Then grouped urticarial papules or papular vesicles. Grouped is the main word to note here. Sometimes in a row are a feature of hypersensitive reactions to bites of various insects, fleas, mosquitoes, bedbugs. 1, 2, 3, breakfast, lunch, dinner. But certainly grouped itchy papular vesicular lesions should again have you thinking of papular urticaria. Palmar pits. We're going to talk about palmar pits. I must admit I tend to think of this just in the basal cell Nevi syndrome. It's one of the features that you've got to go looking for, as well as the prominent forehead, the history of jaw cysts. If you take an X-ray, perhaps calcification of the falx, separating the two cerebral hemispheres. And obviously multiple basal cell skin cancers occurring at an early age. They are subtle. You have to look carefully to see them. I said the commonest condition that occurs is the basal cell nevus syndrome. I suppose, pitted keratolysis, different disorder. It's not really pits. Well, I suppose it's holes in the palms and soles of the feet because it's holes in the keratin. It's due to corynebacteria that, people who sweat excessively, there's overgrowth of corynebacteria and it digests the keratin. So you get these sort of honeycomb-like picture of the thick keratoderma, the thick keratin on the palms and soles. Here were the other causes of Palmer pits. Basal cell nevus syndrome we just talked about, and the other features of that are in DermNet, if we come up to it. The other name for it is Gorlin syndrome. It's good to see a picture of the face actually in this. Remember, this is an autosomal dominant syndrome. They've said 3 or more Palmer pits. They've talked about ectopic calcification of the falx, the odontogenic keratocysts or polyostotic bone cysts. So we'll read up about basal cell nevus or Gorlin syndrome because we've got some new drugs coming along that can affect the gene defect in this condition. So you do need to know something about it. And if they've got a case of Gorlin sitting around, you're going to see it in the exam. Cowden syndrome, normally facial tumors that are associated with, I think, thyroid and breast carcinoma. From memory, it's the tricholamoma that's the facial tumor you get in Cowden's. Darius disease. We've got a whole lot of things, obviously, in Darius, but Palmer pits as well. Must look for that next time. I don't think I have. Pitted keratolysis we talked about. Acrokeratosis verruciformis. Well, that's really an acroform of Darius. Porokeratosis is a cause of Palmer pits. You can certainly get porokeratosis occurring on the palms, palmoplantar porokeratosis. It may mimic a Palmer pit. And there's a little depression there with the surrounding coronoid lamella, but again, must be very rare. We put in this little picture of pustular scabies. Pustules in the soles of the feet in an infant. Always consider scabies. Go looking for features of scabies elsewhere. And remember that in an infant, they can get scabies in the face as well. It's sometimes called infantile acropustulosis, but that really is a form of scabies as well. So go looking for scabitic burrs. Painful nodules in the skin. As I said, the more esoteric painful nodules are listed below. And certainly it's quite a common question is, what are the common painful nodules of the skin? As well as these ones that have been mentioned here, I've said that foreign body reactions or chilblains would be much more common than any of them in terms of painful nodules. And also, the old chondrodermatitis nodularis helicus on the edge of the ear, usually the most prominent part of the cartilage of the ear, that also presents as pain, wakes them up from sleep at night. That's basically necrotic cartilage trying to be expelled through the skin surface. And of the more esoteric ones below, leiomyomas are often painful in the cold. Remember that. And leiomyomas tend to occur in groups. In fact, we've got a picture down here of patient with multiple leiomyomas. The ones in the skin are usually derived from the erector pili muscle. And some of them will react to cold by contracting and become painful. Angiolipomas, glomus tumors. These are painful little nodules, but they usually occur under the nails. This is in dermis, and you've got several examples of glomus tumors here. Let's just have a quick look at this one, because it's probably the commonest presentation of the glomus tumor. See that there? It's usually a darkish purplish sort of lesion like this, and you initially look at it and think that, you know, is it a bruise? Could it be some sort of melanoma? But it's tender, it's locally tender. So glomus tumor, typically occurring under here. Remember, it's a vascular tumor. The glomus cells are found around the arteriovenous anastomosis, linking the, as a sort of bypass system between the arterial and the venous system. It's a shunting system. And you typically get lesions in this location. You can also get glomangiomas, which are group glomus tumors that can occur elsewhere on the body. Have a little look if you've got time at the various presentations on nails here. You can see that it does vary a bit. Eccrine spiroadenoma, not common, but it is listed as one of the painful tumors. There are various acronyms that are sometimes used. I think Bengal was one of them, just to have, you know, the letters corresponding to the letters of these painful tumors. Neuromas, blue rubber bleb nevi, keloids. I don't think that comes into Bengal anywhere. Granular cell tumor, unusual tumor. If you're going to see it, it's probably going to occur in the tongue. Very typical histology for a granular cell tumor. I've seen one before on a forearm. The diagnosis wasn't made beforehand. And dermatofibrosarcoma protuberans. This certainly is an important tumor. It may look like a dermatofibroma initially, but then it grows asymmetrically, and they can be the devil to excise. They don't metastasize, in spite of the name, but you've got to excise them very widely, and by very widely, we usually mean, you know, anything between 3 and 5 centimeters. If you've got a biggish one, to make sure you get it all. I've said here, what's the differential diagnosis of multiple glomus tumors? Multiple ones. Well, they're going to look bluish. It may be some other vascular tumor, like Kaposi's. It might be blue rubber bleb nevis. You might be thinking, oh, but that would have been there from early on. Let me just put in here, see what comes up. Sorry, it's a little bit slow in bringing this up. What have we said? Answer, blue rubber bleb nevis, all right, cavernous hemangiomas, leiomyomas, suppose they can look bluish. Venous malformations, yep. Lymphoma, sure, color-wise. Leukemia cutis, angiosarcomas, Kaposi's, metastatic carcinoma, pseudolymphoma. Yeah, I think that's fair enough. A lymphocytoma cutis, because often these lesions can occur around the ears and things like that as well. Okay, so differential diagnosis of multiple glomus tumors. Where are we on to next? Palmoplantar keratodermas. God, it's a big topic, isn't it? I don't know how many pages of Rook are associated with it. In trying to differentiate the underlying diagnosis of palmoplantar keratoderma that appears to be inherited, it's important to look in the mouth for evidence of leukokeratosis, you know, white areas. Examine the nails, and also whether the patient sweats or not. I've said that a biopsy is only helpful in differentiating epidermolytic palmoplantar keratoderma from the Unothost type. And the Unothost type involves the palms, the soles, occasionally the knees. Keratodermas, you often diagnose them on the basis of other associated features. Now, in Pachyonychia congenita, you've got these massively thickened nails. In the Howell-Evans syndrome, you've got palmoplantar keratoderma with esophageal carcinoma. So it's a marker of an underlying esophageal carcinoma. Now, these are some of the inherited types of palmoplantar keratodermas. Know a little bit about Pachyonychia congenita, so look that up. Know a bit about dyskeratosis congenita. And the hydrotic ectodermal dysplasias. You know, again, there's a whole variant of these, but you know, you look at the kid looks syndromal. You look at the teeth, you look at the nails, you ask about sweating, and then you go to the books and you try and put it all together into a well-known syndrome. Now, conditions with central umbilication. We tried to talk about these beforehand. Molluscum obviously was the main thing. Yeah, I remember the vesicles of varicella when they come up at first. These have a degree of umbilication as well. Sebaceous hyperplasia obviously has a bit of umbilication there on the face. Dego's is that type of vasculitis presenting with these porcelain white lesions on the skin, and you know, it may be associated with involvement of the bowel and other internal organs, and they can bleed into the bowel and get perforation. Cryptococcosis, it's a yeast infection usually seen in AIDS patients. It's a late phase if they start to get cutaneous lesions. You know, they're usually ill, and it's usually the septicemic phase where they've got involvement of the meninges and the like as well, and they die quite quickly. But cryptococcosis can look like molluscum on the forehead. Generalized lichen planus with central umbilication. Can't say I've seen that. Curl's disease. Well, that's one of the perforating cholanginoses, particularly in renal failure patients, particularly in the lower legs. But you know, the only time the central umbilication is where that keratin core in the middle is being pulled out of it. Then it looks a bit umbilicated in those conditions. And then we've said just some other things here. Mixed conditions with central umbilication. Mixed group sebaceous hyperplasia probably being the commonest. Similarity morphologically between disseminated cryptococcosis, we just talked about there, and molluscum. So you got an ill patient who's thin, who may have AIDS, and it looks as if they've got sudden eruption of a lot of molluscum on their forehead, and say they've got a stiff neck on that as well, then it ain't molluscum, it's cryptococcosis they've got. So disseminated cryptococcosis is most likely to be seen in an HIV or immunosuppressed patient presenting with fever and headache. This was a picture of Pachyonychia congenita. Look how gross the keratoderma is. Now remember, in Pachyonychia congenita, look at the nails, look at the inside of the mouth as well, because they'll usually have an area of leukokeratosis in the inside of the mouth. Easier ones now. Lymphangioma circumscriptum. Looks like frog spawn and skin. This is an image of it, not the world's greatest image. Note this, bit of bleeding into these clear vesicles here. That indicates that there's a vascular component to this lymphangioma as well. That's what you often see, that it's not a pure lymphangioma, it may be a combination of both. And though this is on the surface of the skin, you often have to get an ultrasound of the affected area, because sometimes it's like an iceberg. You're only seeing the top area of it, the top tenth of it, the rest of it's all under the skin. They'll weep. If you break the surface of them, they'll tend to ooze and weep. Occasionally they can get secondarily infected. We've said lymphangioma circumscriptum is now usually called superficial lymphatic malformation, presenting as deep-seated vesicles or vesicle-like papules resembling frog spawn. Color can vary from yellowish through pink, red, or dark, depending on the amount of blood. Many have a deep component, occupy subcutaneous tissues and even muscles. Certainly an ultrasound and an MRI should be done to assess the extent, and the CO2 laser is useful, provided there are no deeper components. Obviously the CO2 laser is only going to help seal the superficial component. It'll just open up again if there's a significant deep one. And what have I added in here? I've gone right off topic here. In the differential diagnosis of pyogenic granuloma, always include Kaposi's, yep, because it looks very vascular too. Eccrine poroma, usually you're going to get these in the soles of the feet, palms of the hands. Malignant melanoma, sure, the amelanotic melanoma, you know, can look like a pyogenic granuloma. And so can the Merkel cell tumor. That grows very quickly as well, pink. So again, amelanotic melanoma, Merkel, pyogenic granuloma, they're all part of the differential diagnosis, and why you always have to send tissue. You decide to curette one of these, always send the tissue down to pathology. Because one of these days you'll be curetting a Merkel cell thinking it's a pyogenic granuloma. Erythema nodosum, we've gone into that already. Just a little bit of revision. Painful red tender papules and nodules in the legs, particularly over the shins. Surrounding bruising is the involute. Can occur in crops. Ulceration does not occur, as against erythema geratum, and lesions usually resolve without atrophy or scarring. Look for an association with sarcoid and drugs. The old days, bromides, iodides, sulfonamides. And oral contraceptives, I think they're currently the most common drug inducing erythema nodosum. I suppose because there's so many people on it. This was just a picture here of erythema nodosum. Actually, if I was to look at that just now, I would have thought that was a cellulitis rather than erythema nodosum. Usually it's a lot more localized and a bit of bruising around the outside. But it's like most things in medicine, there is variation. Macroglossia. It's taking us a while to come to this. Have a little look at this lovely old lady. You know, look at that tongue. It's almost occupying the whole of the inside of the mouth there. There's hardly room there to close the mouth with a great big tongue. And that one was thickened because of infiltration in amyloid. It's a lady, I think, had myeloma, and amyloid protein was infiltrating the tongue, giving macroglossia. Often you'll see indentations of the teeth around the outside of a tongue that's involved with this. The other thing you'd have to think of there is hypothyroidism. Go looking to see if there's any loss of the outer third of the eyebrow, feel the skin, look to see if there's carotenemia. But that can, cretinism, hypothyroidism can also give macroglossia. But she had amyloid. So causes of macroglossia. Tumor. Yes, indeed, a tumor of the tongue could certainly present with macroglossia. Thiamine deficiency. They're going to have a degree of angular cheilitis if that's the case as well, if there's vitamin B deficiency. Systemic amyloid, we've said, hypothyroidism. Angioedema, well, you'll get macroglossia, but it's going to be episodic. It's going to be up and down. And sometimes you can get just half a tongue swollen in angioedema. Interstitial glossitis. I'd need to look that up. I'm not quite sure what that actually is. Interstitial glossitis. Is it some sort of strep infection? Don't know. And pemphigus vulgaris as a cause of macroglossia. Usually think of it in the mouth as a cause of ulceration. Remember, about 90% of cases of pemphigus are going to present with oral ulceration. In fact, they may present with the oral, they'll present with the oral ulceration before they'll get blisters or lesions in the skin. Hemangioma of the tongue, yes. Melkeson-Rosenthal, that one you should know a little bit about. And that's the association of a large tongue with, I think, eyelid problems and a thick lip as well. What's Melkeson-Rosenthal? Refers to recurrent, chronic, long-lasting swelling and enlargement of one or both lips. Ah, right. Facial palsy, muscle weakness, and fissuring of the tongue may also occur. There's no known cause for the syndrome. Genetics may play a role as members of a single family have been affected. It's rare. So, Melkeson-Rosenthal. Who has they call it the scrotal tongue, the fissuring of the tongue that they in fact have, and the recurrent swelling of the lips, and the variable facial palsy of the Melkeson-Rosenthal syndrome. Okay, and lastly, boinoid papulosis. It took me a wee while before I got clued into boinoid papulosis. Generally, these lesions are going to occur on the glands, well, on the shaft of the penis or in the female labial area. The lesions look, when they're brownish like this, like seborrheic keratoses. If they're pink, they're going to look like simple genital warts. But I must admit, I tend to go for the diagnosis when I've got that browny color associated with them. If you do a shaved biopsy of one of these, the histology that you see is of an in situ SCC. And because it's induced by an oncogenic papillomavirus, I think 6 and 16 are probably the commonest of the oncogenic ones affecting the genital skin, but double check that for the HPV types involved in bonoid papulosis. They don't really form invasive SCCs. I can't say I've seen that. They can be treated with destructive methods. A lot of them I just shave off if there's not too many, and just lightly cauterize the base. That's the quickest and easiest way of dealing with them, and flip them down to pathology. You can trial imiquimod with them. It can work quite well in bonoid papulosis. But it's, remember, it's an in situ carcinoma. These lesions are often hyperpigmented flat papules seen in groups, particularly on the penis or perianally. Histology shows cellular atypia similar to Bowen's, usually caused by HPV-16. So there were some other questions here. Bonoid papulosis on glabrous skin is less likely to show malignant change than the same lesions on mucosal skin. True or false? Well, if they're not showing those changes, how do you call them Bowen's? Let me just see what we've put as the answer to that one. What have we got here? Bonoid papulosis is less likely to show malignant change than the same lesions in mucosal skin. True or false? True. On glabrous skin, bonoid papules behave almost like normal warts, but on mucosal surfaces of the gland penis may have an increased risk of forming squamous cell skin cancers. Do they mean, or does that mean invasive squamous cell skin cancers? I reckon I need to look up bonoid papulosis to see. Well, let's finish by having a quick look at eMedicine here and seeing what they say about bonoid papulosis. Described 1977. Both sexes, papules induced by papillomavirus, distinctive histopathology. Many bonoid papulosis lesions appear to run a benign course, though a number of case reports associate bonoid papulosis with malignant invasive transformation. All right, so it can occur, but it's uncommon, 2.6%. So there is a small increased risk of invasive SCC with bonoid papulosis. So that's one of the reasons why we should in fact treat this. But it would appear that this is most likely to occur when this type of virus is seen in mucosal areas rather than if it was seen on glabrous skin. Might be worthwhile going in here and having a look at some of the other images and the like that they have of this was just the histopathology that they have. We'd need to go in and look closely at this, but we'd see that there was atypia, that we'd see that there were mitoses and the like, the typical features, and overlying parakeratosis, the typical features that you would see in Bowen's disease. Yep, there they go. Look at the variation, the size and the nuclei of the cells in that epidermis. And I'm sure if you looked in carefully, you'd actually see mitoses and the like as well. And this is a vulva with these lesions, wart-like lesions. You'd have to consider ordinary warts, bonoid papulosis. You might even consider lichen planus in someone like this. You might even consider, what's the other one I was trying to think of? Nope, gone on my head. So, they one in syphilis. That secondary syphilis, they can get lesions that may look like this as well. So you need to consider that in your differential diagnosis. Okay, well, there's been quite a lot of stuff that we've looked over there today in this particular talk. There's a whole lot of issues, a whole lot of conditions here. If there's any of them that you don't know a lot about, then go to one of the links, have a little read about it, just fill yourself in. I mean, there are a lot of rare syndromes here that I haven't sort of highlighted, given links to. We may do that later on in another one. I don't link them all in each of these tutorials that we do. But they're important conditions. You should know a little bit about them. And I hope we've stimulated your interest in some of these today. Thank you very much.